In this next portion of the module, we will be covering three special cases. First is C. diff colitis, which is caused by Clostridioides, previously Clostridium difficile. Then listeriosis, caused by Listeria monocytogenes. And lastly, Whipples disease, caused by Trophorema whipplei. Please note that all of these are gram-positive rods. In our first case, we have a 65-year-old male who presents with foul-smelling diarrhea. One of his medications is a proton pump inhibitor, or PPI, for gastroesophageal reflux disease. Additionally, he was recently discharged from the hospital for a skin infection. During that time, he received IV antibiotics in the hospital and was discharged home on oral clindamycin. He is now having 5 to 10 watery stools per day. He has associated lower abdominal cramps, and additionally, he has a low-grade fever. Workup includes a CBC with a white blood cell count of 18.5 thousand. This is a case of infection with Clostridioides, previously Clostridium difficile, also simply known as C. diff. C. diff is a big topic as it is a common healthcare-associated infection. The most common clinical presentation occurs after a course of recent antibiotics. Antibiotics disrupt the normal gastrointestinal bacterial flora, giving rise to pathologic C. diff growth and infection. It presents clinically with what we call C. diff colitis, with watery, foul-smelling diarrhea, often 5 to 15 times per day. There's also often associated abdominal cramps and possible fever. While many bacterial infections can lead to elevation in white blood cell count, C. diff specifically is often associated with leukocytosis, and you should remember that. Please note that while we think of antibiotics causing C. diff, many antibiotics also have diarrhea as a side effect. Remember that just because a patient is on antibiotics and gets diarrhea does not mean that they have C. diff. C. diff is relatively common, and you will see many cases throughout your career. It's transmitted through ingestion of spores through fecal-oral route. Besides recent antibiotics, other significant risk factors include recent hospitalization, elderly patients, immunocompromised, and proton pump inhibitors, as we described earlier in this case.
C. difficile is a gram-positive, spore-forming anaerobic bacillus, features which are shared in general by Clostridium bacteria. In this gram stain, you can see purple gram-positive rods or bacilli, which have spaces consistent with spore formation. If you examine such bacteria at very high power with electron microscopy, these spores can be better visualized as seen here. The two key toxins of C. difficile are, of course, toxin A, which increases inflammation and fluid secretion, and toxin B, which is directly cytotoxic to colonic epithelial cells. Pseudomembranous colitis is a key complication of C. difficile infection, and due to the close association with antibiotic use, it has also been termed antibiotic-associated colitis or antibiotic-associated diarrhea. The pathogenesis of pseudomembranous colitis is complex, but stems from the elaboration of the two aforementioned toxins. It is thought that ribosylation of GTPases interferes with the colonic epithelial cytoskeleton and tight junctions, ultimately leading to apoptosis of the colonic epithelium. Attracted neutrophils spew out onto the surface, leading to a purulent layer of adherent inflammation, which appears as adherent elevated yellow or white plaques. Here we see such findings on an endoscopic picture of the colon taken during colonoscopy. Histologic evaluation of these plaques reveals a volcano-like surface inflammatory eruption of pink fibrin and neutrophils stemming from the necrotic disruption of the colonic surface due to the toxins. The arrow here is a point of colonic epithelial loss consistent with epithelial necrosis. And here we see the surface abundant pink fibrin and material which on higher power would be associated with abundant acute inflammation. Toxic megacolon is typically thought of as a complication of ulcerative colitis, but can also be seen in severe C. difficile infections. Marked inflammation of the muscularis propria causes neuromuscular dysfunction and marked colonic dilation. The condition can be fatal, especially when perforation, which is a definite risk of this condition, occurs. Here we see a case of a markedly dilated colon, consistent with toxic megacolon, seen in a case of C. difficile infection in which emergent surgery was performed.
Workup for C. difficile is through stool toxin antigen, remember toxin A and toxin B, versus stool PCR. Typically, colonoscopy is not performed unless evaluating for other causes of diarrhea. Imaging may be considered if there's a concern for toxic megacolon, which could include patients that have severe abdominal pain, abdominal distension with lack of bowel movements, or suddenly they're not having diarrhea anymore, or patients with hypotension or marked leukocytosis. Typically, CT abdomen and pelvis with IV contrast would be ordered to evaluate for toxic megacolon. However, abdominal X-ray could be considered if CT is not available. In this image, we can see a patient with toxic megacolon due to C. diff with dilated large and small bowel throughout. Treatment for C. diff colitis is typically with oral vancomycin. Alternative agents include Dexomycin, which is a more recent recommendation, and metronidazole, which has been used for many years to treat C. diff. Fecal microbiota transplant may be considered for recurrent or refractory cases of C. diff. It plays on the causative nature of how C. diff infections occur from antibiotics killing the normal gastrointestinal flora, allowing pathologic C. diff to flourish. It's performed by taking stool microbiota from healthy individuals and administering it to patients with recurrent C. diff, typically through enema, to restore the healthy strains and break the cycle of recurrent C. diff. Prevention of spread of C. diff is important, especially in the hospital setting. Normal alcohol cleansers do not kill the spores of C. diff, so it's important to wash hands with soap and water, as well as clean all contacted surfaces with bleach, which contains hypochlorite as the active ingredient.
Glycopeptides, including vancomycin, are common drugs of last resort. For many years, vancomycin has been relied upon as a go-to drug for treating multi-drug resistant MRSA and ORSA. As a result of its increased use, bacteria have developed resistance to vancomycin, and that is now a growing concern.
This drug is recommended intravenously as a treatment for complicated skin infections, bloodstream infections, endocarditis, bone and joint, meningitis, and MRSA. Blood levels are likely to be measured to determine the correct dose. It's recommended by mouth as a treatment for C. diff colitis. When it's taken by mouth, it's very poorly absorbed. This drug's mechanism of action is to prevent cell wall formation by binding to D-ala oligopeptides. One of the main uses in the GI system for vancomycin is to treat C. diff. And when you're doing that, you use oral vancomycin. You use IV vancomycin for most other infections. High-yield adverse reactions include so-called red man syndrome. In order to avoid that, you can pre-treat with antihistamines. Slower infusion rates also help. It turns out vancomycin causes the degranulation of mast cells. Other high-yield adverse reactions for vancomycin include nephrotoxicity, ototoxicity, thrombophlebitis at the injection site, and so-called DRESS syndrome, which stands for drug reaction, eosinophilia, and systemic symptoms.
Antibiotic-resistant bacterial strains are spreading rapidly, both in this country and around the world. For example, vancomycin-resistant enterococci and fluoroquinolone-resistant Pseudomonas are shown here in these two lines. I'd like to focus on vancomycin resistance. Vancomycin is a cell wall synthesis inhibitor that's been employed for over 60 years. Bacteria have learned to generate alternate peptidoglycan precursors. Resistant strains produce D-ala, D-lac, or D-ala D-cere instead of the wild type D-ala, D-ala at their C termini. And it turns out the drug vancomycin has a poor affinity for these alternative moieties. Shown diagrammatically, vancomycin-sensitive cells, when treated with vancomycin, produce unstable cross-links, and that's how vancomycin kills these bacteria. Whereas vancomycin-resistant cells have this mutation that produces stable cross-links. Thus, the bacteria are resistant to vancomycin. Fidaxomicin is considered a macrolide antibiotic. It's a relatively new macrocyclic antibiotic, and it's the first member in a new class of narrow-spectrum antibiotic drugs called tiacumicins. They're also called macrocycles, and they contain this very complex 18-membered ring. Now, fidaxomicin is a fermentation product of a specific gram-positive soil-based bacterium called Dactylosporangium aurantiacum. Fidaxomicin produces its antibacterial effects by inhibiting bacterial RNA polymerase at initiation of transcription. Both fidaxomicin and rifamycins inhibit bacterial transcription. However, the mechanism of action of fidaxomicin is distinct from that of rifamycins. Resistance to fidaxomicin is not cross-resistant with rifamycins. That's because fidaxomicin acts at an earlier step in the transcription initiation pathway. Specifically, fidaxomicin binds to the DNA template RNA polymerase complex and prevents the initial separation of DNA strands. This has an added benefit, specifically in that isolates of C. diff resistant to rifamycin, cephalosporins, and fluoroquinolones, as well as clindamycin, are not cross-resistant to fidaxomicin. RNA polymerase is the target of numerous antibiotics to include fidaxomicin, mixopyronin, and rifamycins. But each of these antibiotics targets RNA polymerase at a different stage of RNA transcription and at a different site in the enzyme. You can see fidaxomicin inhibits the earliest step of RNA polymerase function.
Next, we turn to a 26-year-old pregnant female with diarrhea and fever. She's 30 weeks pregnant in her third trimester. She recently ate cold-cut sandwiches at a luncheon. Now she's having flu-like symptoms with fever, myalgias, and abdominal and back pain. She also is having watery diarrhea with nausea and vomiting. Blood cultures are obtained and show gram-positive rods. This patient is infected with Listeria monocytogenes. Listeria monocytogenes is typically not of major concern in healthy, non-pregnant patients. It often causes mild, self-limited gastroenteritis with fever, watery diarrhea, nausea, vomiting, and myalgias, with incubation period of only about 24 hours and symptoms usually resolving within about 2 days. Pregnant patients, however, are at increased risk of bacteremia from Listeria and may present with persistent fever, chills, and other flu-like symptoms. Other than the risk to the mother of bacteremia, there's also a risk to the pregnancy with risk of fetal loss, preterm labor, and neonatal sepsis. Invasive disease, such as with bacteremia, typically has a longer incubation period of about 10 days. While Listeria is uncommon, it can cause foodborne outbreaks. It is typically transmitted through ingestion of contaminated deli meats, unpasteurized milk, or soft cheeses made from unpasteurized milk. Additionally, in pregnant patients, it can be transmitted transplacentally or vaginally at birth to the infant. This is called vertical transmission when it's passed from mother to baby. As we noted before, it's not of major concern in most healthy non-pregnant patients. However, in immunocompromised, pregnant, and elderly patients, there's an increased risk for invasive disease with bacteremia or CNS involvement causing meningoencephalitis.
Listeria monocytogenes is a gram-positive anaerobic rod whose virulence is tied to its ability to live intracellularly. It grows at cool, refrigerator-level temperatures, which is a key characteristic. It has many flagella, which gives it a tumbling type of motility. On gram stain, we see purple gram-positive rods, or bacilli form. Here we see a scanning electron photomicrograph of Listeria monocytogenes showing the numerous flagella. The virulence factors of Listeria monocytogenes allow it to invade into cells, avoid lysosomal lysis, and move to a nearby cell using actin-based motility, in effect giving it the ability to be an intracellular pathogen. Listeria is able to not only invade enterocytes, but also escape phagolysosomes of macrophages. Following the intracellular route of Listeria monocytogenes within a cell, we see that the bacteria gains entry by its internalin proteins. Its greater trick, however, is its ability to escape intracellular capture through lysing intracellular vacuoles, through listeriolysin O and phospholipases. Listeriolysin O and phospholipase are the two key virulence factors to remember. Now, after escaping lysosomal lysis, the bacteria can also mobilize actin structures to migrate to an adjacent cell.
The workup for Listeria is predominantly with blood cultures and potentially CSF cultures. It typically does not grow well on stool culture and is not included in the GI pathogen PCR. However, you may consider stool culture or PCR to rule out other causes of diarrhea. Treatment of Listeria should include those that have blood or CSF cultures positive for Listeria. Additionally, you should treat pregnant patients in whom Listeria is suspected based on symptoms and potential exposure, even if you don't have positive blood or CSF cultures back yet. The antibiotic of choice is IV Ampicillin, which is a penicillin.
Here is a slide depicting different classes of antibiotics and provides a broad overview. Note the key: some commonly act as bacteriostatic while others act as bactericidal agents. Let's go for a deep dive into beta-lactam antibiotics. One example, Ampicillin. Please recall Dr. Seeger's Skin, Blood, Lymph lecture. I've taken a slide from that lecture to emphasize the fact that Ampicillin is an extended spectrum antibiotic. A little bit later, I'm going to emphasize the use of cell wall synthesis inhibitors with beta-lactamase inhibitors due to bacterial resistance. There are 5 classifications of penicillins to include the source, route of administration, spectrum of activity, resistance to beta-lactamases, and resistance to acid hydrolysis. As you can see from this chart, Ampicillin is a semi-synthetic, broad-spectrum antibiotic that's sensitive to beta-lactamases and is acid stable. Ampicillin can be administered by mouth, intramuscularly, or by IV infusion. For IV infusion, injections must be given slowly, as rapid IV injections can lead to convulsive seizures. The mechanism of action of penicillins is inhibition of bacterial cell wall synthesis. Let's talk briefly about allergic versus anaphylactic reactions. With respect to allergic reactions, 5 to 10% of patients have been reported to experience allergic-like side effects. Most of these reactions are minor, to include mild rash, itching, or skin flushing. Only a very small fraction of these patients will have serious reactions when challenged with another beta-lactam antibiotic in the future. That's not to be confused with anaphylactic reactions. Beta-lactams can rarely produce this potentially life-threatening type of reaction. It's actually less than 0.04% of drug administration, and it's not the most commonly observed side effect. While ampicillin is a penicillin derivative, the group of beta-lactam antibiotics is rather large, as shown in this slide. Penicillins are amongst a subgroup of beta-lactam antibiotics. Others include cephalosporins, to include first, second, third, and fourth generation cephalosporin antibiotics. Carbapenems and monobactams, all are beta-lactam antibiotics. Because ampicillin is susceptible to penicillinases, you need to have a deep understanding of penicillinase enzymes and penicillinase-resistant penicillins. All penicillins destroy bacteria after binding to penicillin-binding proteins. You can see that here. Penicillin targets penicillin-binding proteins to destroy bacteria. Penicillinases are enzymes produced by bacteria that destroy penicillins by cleaving the beta-lactam ring due to their active site similarity to penicillin-binding proteins. And you can see that here. The penicillinase binds to penicillin and destroys it. Beta-lactamase inhibitors act as a decoy drug that enhances the activity of penicillins by binding to the active site of the penicillinase, rendering the enzyme inactive. allowing the drug to destroy the bacteria. In the combination of amoxicillin and clavulanate, called augmentin, clavulanate inhibits the penicillinases. It's used for hospital-acquired pneumonias. Gram-negative and gram-positive coverage is achieved. Moreover, this drug covers beta-lactamase-producing organisms. It's delivered orally, unpleasant side effect of causing diarrhea, and it also has anaerobic coverage.
In this last case, we have a 75-year-old male with chronic arthralgias, weight loss, and steatorrhea, which is fatty stools. He's a farmer and started having joint pains in his knees, wrists, and ankles several months ago. Later, he started developing gastrointestinal symptoms with colicky abdominal pain, chronic steatorrhea, or fatty greasy stools, and is now noted to have unintentional weight loss. Ultimately, this patient was diagnosed with Whipples disease caused by Tropharema whipplei. The bacteria Tropharema whipplei is ubiquitous in the environment, but rarely causes disease. It can, however, invade a human host and spread throughout the body, including the intestinal mucosa, mesenteric lymph nodes, and through many organs, which can cause multi-system disease. It leads to small bowel atrophy with resultant malabsorption. The classic 4 cardinal manifestations of Whipples disease are arthralgias, which can vary significantly, but often involve peripheral joints, including knees, wrists, and ankles. Chronic diarrhea, which classically is steatorrhea due to malabsorption. Colicky abdominal pain, and ultimately weight loss from malabsorption. Additionally, it can lead to vitamin deficiencies secondary to the malabsorption, as well as peripheral edema due to decreased albumin. Usually, GI symptoms present later in the course of the illness. As noted, it can involve multiple organs, with some of the more common ones shown in this cartoon being cardiac, arthralgias, and neurologic symptoms. You can remember the acronym CAN, C-A-N, as in whipped cream comes in a can. It's important to recognize while this disease can be very serious, it's also quite rare. It's uncertain definitively how it's transmitted. However, it does occur more commonly in older males as well as farmers and others who have exposure to soil and animals.
Whipples disease is caused by Tropharema whipplei, which is a gram-positive intracellular bacterial rod. Tropharema whipplei, however, belongs to the actinomycete order, similar to actinomyces. Although the specific virulence mechanisms are unclear, the primary pathogenesis of Whipples disease caused by Tropharema whipplei involves the bacteria's intracellular accumulation within numerous macrophages. Partially digested organisms within the macrophages distend the lamina propria of the small bowel, causing malabsorption. They can also accumulate within mesenteric lymph nodes, synovial membranes, cardiac valves, and other organs, causing lymphatic distension and disease. Interestingly, there is an immune dysfunction that is thought to be partially responsible for the disease, as individuals with an impaired T cell response are more susceptible to Whipples disease. Oftentimes, Whipples disease is diagnosed by small bowel biopsy, as the bacteria are difficult to culture. Here we see a biopsy of small bowel with marked distension of the lamina propria with abundant macrophages. Such macrophages cause blunting or atrophy of the normal villi of the small bowel. A key feature of the organisms are that they are positive for PAS, or periodic acid shift stain. This inset picture here highlights PAS positive organisms in red. Now, don't confuse this stain with an acid-fast mycobacterial stain used for acid-fast bacilli, because although Tropharema whipplei is positive for PAS, it is not acid-fast positive.
You may consider workup for possible Whipples disease in patients with arthralgias, diarrhea, specifically steatorrhea, abdominal pain, and weight loss. Again, as this is very rare, you should certainly consider alternative diagnoses as well. One test that can suggest the possibility of Whipples disease is fecal fat. Specifically, you can look at stool Sudan stain, which would indicate fat in the stool as depicted in this picture. Fecal fat's not specific to Whipples disease and could be positive in any disease that leads to fat malabsorption. The best test to diagnose Whipples disease is an upper endoscopy or EGD with the biopsy of the small bowel with PAS staining, as Dr. Hillard discussed. You may hear the term foamy macrophages referring to the abundant bacteria-laden macrophages in the lamina propria. Whipples disease is fatal if untreated. Initially, it requires intravenous penicillin or ceftriaxone, which is then followed by oral sulfamethoxazole trimethoprim for 12 months.
Ceftriaxone is a cephalosporin antibiotic that has a beta-lactam ring, is a third-generation cephalosporin, and is a cell wall synthesis inhibitor. If you click on the link, the package insert will be revealed to you. The original cephalosporins, i.e. the first generation, were most effective against gram-positive organisms. Subsequent generations broadened their spectrum to include more effectiveness against gram-negative organisms. This reduced their effectiveness against gram-positives. However, they became more resistant to beta-lactamase enzymes. IV infusion of ceftriaxone penetrates the CSF. It's excreted mostly in bile, with the remainder excreted renally. There's a long half-life with ceftriaxone. There are undesirable side effects associated with ceftriaxone, including egg calculus cholestasis and bilirubin displacement from albumin. Should use cautiously in neonates and avoid use in jaundiced infants. Do not use this drug with calcium-containing solutions due to a precipitation hazard. That is, calcium will come out of solution when mixed with ceftriaxone. Anti-metabolite antibiotics inhibit folic acid synthesis in bacteria. Two folic acid synthesis inhibitors include sulfonamides and dihydrofolate reductase inhibitors. The two I'm referring to are sulfamethoxazole and trimethoprim, together called Bactrim. Let's talk about Bactrim's mechanism of action. In bacteria, nucleotide and DNA formation require tetrahydrofolate synthesis, and this synthetic pathway uses para-aminobenzoic acid, also called PABA, as a beginning substrate. While this is required in bacteria, humans derive tetrahydrofolate totally from our diet. In other words, we have no Th4 biosynthetic pathway in our endogenous biochemistry. You can see the structural similarity between PABA and sulfonamides. Sulfamethoxazole mimics PABA to inhibit the first step in tetrahydrofolate synthesis, shown here. Trimethoprim blocks the last step in the synthesis of tetrahydrofolate, shown here. So the combination of sulfamethoxazole and trimethoprim, aka Bactrim, acts synergistically to cover many gram-negative and gram-positive bacteria. However, there is no anaerobic coverage, while there is some protozoan coverage. This combination of sulfamethoxazole and trimethoprim, which you sometimes see as SMX-TMP, also called Bactrim, has certain potential adverse effects in neonates. In particular, sulfamethoxazole demonstrates a frequent incidence of kernicterus. Sulfonamides are highly protein-bound to albumin. Sulfamethoxazole displaces bilirubin from its albumin binding sites in plasma, and when elevated levels of free plasma bilirubin occur, it crosses the blood-brain barrier to reach the central nervous system. Kernicterus results, and here's a definition for kernicterus. Hyperbilirubinemia that results from the displacement of bilirubin from albumin by sulfamethoxazole may cause bilirubin to accumulate in the gray matter of the central nervous system, potentially causing irreversible neurologic damage. Depending on the level of exposure, the effects range from clinically unnoticeable to severe brain damage and even death.
Again, we have a table here summarizing some of the features of the pathogens we've discussed. This is a great study tool, but don't forget to reference the other slides as well. A few things to note here. These are all gram-positive rods, with C. diff being anaerobic. Again, you can see some of the important clinical features, transmission, epidemiology, pathologic features, and complications associated with these pathogens. This is the same table, but with the last two columns being changed to workup and treatment, so you can see the recommended workup for these pathogens, as well as the recommended treatment.